our second talk speaker is Mr. Christopher Liu, Professor Christopher Liu. He's a consultant corneal surgeon based in Brighton, England. And he is also the honorary treasurer of the Royal College of Ophthalmologists. He will be speaking about Dmek. Please, Christopher.
Thank you. Can you all hear me?
Yes, it's clear.
Great. I think I'm going to have some problem with IT. So if my PowerPoint freezes, then I may well need to start again. So I'm talking about Dmek as requested by Dr. Nancy Al-Rakad, and I'm going to try and give you a roadmap instead of showing you many videos. I have no financial interest in this subject. So in terms of why do selective endothelial keratoplasty? Well, we have these advantages that we have speed of visual rehabilitation. So if compared with a PK or PKP previously, when using a full thickness graft to as a carrier for endothelium, we had to wait 1 or 2 years before we had full visual rehabilitation. Whereas with Dmek, it could be just a few days or a few weeks. The physical strength of the globe is really important because it's all done through keyhole surgery. And because the graft, either Dmek, DZAIC or DZEG, is so much thinner, there is little refractive change. And in fact, there is hardly any refractive change with Dmek, although there will be some because the peripheral cornea is a little bit more swollen with edema, and when it detergesses, it does change by about 1/4 of a diopter. So because we haven't changed the shape of the host cornea, there is very little graft astigmatism as well. And because we are transplanting much fewer antigens, there is much reduced immunological rejection rates. And of course, within the anterior chamber, there is also anterior chamber associated immune deviation protecting anything which is within the anterior chamber. So why Dmek and not DZAIC or DZEC or PDEC? Well, we're replacing like for like. In other words, we remove Descemet's membrane and endothelium, and we are putting back endothelium and Descemet's membrane. And we have shown ourselves, and many others have also shown that Dmek is superior to DZAIC and DZEC in terms of visual quality. So for example, if you have one eye Dmek and the other DZEC or DZAIC, the patient will always prefer the Dmek eye. However, there are some disadvantages, that there is a significant learning curve. It is not an easy operation, and the rebubbling rate is higher. So should I learn Dmek? I think the answer is yes. However, there will be a case of not wanting to change to Dmek if you are already happy with your DZAIC technique, and you are like within a few years of retirement, so that's fine. If you're happy with your ultrasound DZAIC results, then that's also fine. And of course, there are a number of PDEC aficionados who prefer that technique too. So how should I learn Dmek? Well, like attending webinars and studying the literature, and there are many, many videos that you can watch as well. And this particular website, patientready.org, I can recommend to you. There are a number of videos there which are very, very clear, and they have been carefully edited for educational purposes. Well, in my case, I also learned from a couple of masters, Professor Friedrich Grüß and Professor Marc Mirain in Germany and France, respectively. So then you've learned, then you can practice using a wet lab model, which I'll show you. And then to begin with, then ideally, when you start, then you should have somebody supervise you to begin with. So here, I show you what's necessary for wet lab practice. You have an anterior chamber, and you need 2 corneas which have been donated for research or teaching, and you need 2 per Dmek graft. And you can see all the instruments on the right. They can be, because we're using human tissues and not animal tissues, these can be re-sterilized for normal operations, and we can practice when the afternoon list is finished, and then we can do a wet lab practice and then pack up and go home. Let's hope for the best. So we have the side ports, and then here I'm using an IOL injector which is sealed, and I put a little bit of fluid there to free up the graft from the side of the injector. So the graft goes in, and then you come out. And here we are just using external waves and pressure to try and open it up. Then we realize that it's actually upside down. So you need to deepen the anterior chamber and change it to the correct orientation. And then you can try and smooth it out again. Now here's a bimanual technique, one hand holding one side and the other smoothing it out. And then refill with air. And that's it. So that's the end of this. So let me just go through the different steps with you. Case selection, donor selection, donor preparation, desmodorexis, graft insertion, graft unfolding, upside down Dmek, rebubbling, and some areas of controversies. So case selection, I would start with symptomatic Fuchs endothelial dystrophy. We have symptoms of morning blur and thickened cornea and central guttata, and ideally with coexisting cataract. That's when you remove that, then the patient will also notice even further visual improvement. Now, I would actually advocate phaco Dmek even if there was not much cataract, because you don't really want to do the Dmek and then have to disturb it afterwards with another cataract operation. Now, for a novice, it would not be a good idea to attempt cases where there is a anterior chamber implant or no lens diaphragm. Donor selection. Now, if you tell the eye bank that you're doing a Dmek, then they should select older donors to avoid tight scrolling. The younger the patient or the younger the donor, the tighter the graft will scroll. So ideally, let's say 50 or 60 years upwards. Obviously, you need good endothelial density. The eye bank will control all that for you. Ideally, the donor has not had cataract surgery, because the cataract wounds, of course, they go inside the eye as well. And when you're trying to peel the Dmek, it can be difficult to maneuver, because sometimes the internal wound of a phaco wound can be quite far in. And ideally, avoid diabetic donors, because the peeling is more difficult. So here's donor preparation. There are many, many methods, but what you must do is you must go inside the within the trabecular meshwork, because otherwise, now here you see actually this eye has a defect on one side, and that may well be the cataract wound. But anyway, we only had one piece of tissue, so we'd have to just go along with it. So stain and stain repeatedly and stain well, but be aware if you stain too much, it can be toxic to the endothelium. So once you have removed the peripheral Descemet's membrane, then you create a liftable edge, and you make sure that any tags, just like your imperfect rexes in cataract surgery, you correct that. It needs to be a continuous tear on the outside. Now, some eye banks will pre-peel for you, and they will charge for this service. I have very limited experience of implanting a pre-peeled membrane. That cornea came from America, and it took 8 weeks to clear. It was quite frightening because I've never had to wait that long for a Dmek cornea to clear. And the other thing is that final point, make sure your peel is successful before you start operating on the patient. I mean, to my horror, I have seen a patient who could not have the graft, and in the end had some substandard graft because the peeling was not successful, and it was converted into a manual DZEC, and I had to exchange that to a Dmek through another operation. So punching, removing, and then you have this in a swimming bath, and it curls up as it wants to. The younger the donor, the tighter it curls. If you have a very young donor, it will curl into a little, like a little pencil. It's very difficult to open then. So desmetorexis, you can do under MVisc or Helon, and that is much better than doing under air because your air keeps escaping. But never put any HPMC or dispersive viscoelastic in the eye, because that would stick to your back of the cornea and you will never get your Dmek to adhere. Mark the epithelium with the trephine, the same trephine that you trephine your Dmek graft with, and then scour from the inside, making your circular mark, and then scrape, but making sure not to damage the posterior stroma. And then check that you have removed all the endothelium and the desmase membrane, and generally speaking, the area of desmetorexis should be at least the same size as your Dmek graft. Now, a small islands of partial thickness and desmase membrane left behind doesn't matter. Sometimes they cannot be removed. So if you keep scraping, you just damage the posterior stroma. Now, the visibility can be improved by removing opaque epithelium. If the epithelium is opaque, if the cornea is really, really thick, then you can detergess it with glycerol. You can also stain what's inside the anterior chamber. You can use different lighting with endoillumination to try and improve your visualization. Now, graft insertion, there are many, many methods. Basically, you've seen an IOL cartridge. You can also use a glass pipette, and there are some devices which allow you to pull through a graft as well. So the important tips, head positioning is really important. You want the eye to be facing the sky completely. So if you put a small bubble inside, the bubble should go to the middle of the cornea. That means the eye is in the correct position. The other thing is, once your graft is in, before you withdraw either the cartridge or the pipette, just make sure if you have high intraocular pressure within, or if you've got an AC maintainer, turn that off. Otherwise, your graft will just come out through the main wound, and then you will have to look for it. And of course, there will be a lot of endothelial damage. And then seal your wounds before attempting to unfold graft. Graft unfolding, there are many, many videos that you can watch. And remember, I took out this website. This is really good as a starter. And then there are many YouTube videos that you can watch. Basically, do not access your graft through the main wound. Access your graft through the side port, either with cannula or with even a little hook sometimes. Okay, do not touch the endothelium as far as possible. So do non-touch as far as possible. And from the outside, manipulation is by tapping, by manual holding and milking to unfold, which you saw in the video just now. And if you shallow the anterior chamber, it encourages unfolding and stops it re-scrolling again. However, if it's in a taco shape or if it's upside down, then you have to deepen the anterior chamber to reorientate it. Otherwise, it hasn't got the room to turn round. If you have a graft which is already on the back of the cornea and it's not quite centered, that what you can do is you can put a small bubble in, and then whilst your assistant is wetting the cornea, you can use a squint hook and beat the top of the cornea, which is constantly wet, so as not to take off the epithelium. If you keep beating it and holding the eye with the fixation forceps on the other side, then you can push the graft into the correct position, and then you can secure that with more air in the anterior chamber. So here, how do we know that the graft is the correct way or upside down? Now, the graft always opens with the endothelium on the outside. So there is this thing called the Musuri sign, that when you have a cannula within the scroll, and when you move it, then if you are in the correct orientation, then you will see that up here, the cannula will not be completely silver, but will have some blue coloration because you're looking through a scrolled graft which is above it. Instead, on the other side, here, if the graft is upside down and your cannula is above it, then you don't see any blue. However, you can be fooled because you can have the silver cannula underneath an upside down graft, and then you think that, oh, it's blue, it's all right. So you need to watch the behavior very, very carefully. What can be done to help then? Some people make peripheral marks, asymmetric marks. Some people stamp the graft with S or F stamps, so you know it's the correct orientation. Some people are very lucky, they have intraoperative OCT, and here you can see some examples that in this area you can see that this graft here is curled upwards here, so it is the correct orientation. It's important that if the graft is upside down, you can save it if you reorientate it through a separate procedure within the first few days. If you leave it for long, then it cannot be saved and you need to do a regraft. If it adheres to the cornea and it doesn't clear and it's upside down, it's not proof that it is not upside down, because if you have, for example, SF6 in the eye, you can press an upside down graft into adhering, and you might think that it's a primary failure, but it's actually our own fault for having it put it wrong in the first place. If you record all your operations, then you can go back and watch and see whether you've made an error of judgment. So in terms of rebubbling for detached Dmek graft, the criteria for different surgeons is very, very different. Now, some people will leave things for a little while and see what happens, and then a lot of times it will attach by itself. Other people, like myself, I see a bit of detachment, I get worried, and I would do some air or SF6. So the controversies within this area of rebubbling is, do you do it at the slit lamp or the operating theatre? Well, slit lamp is actually fine, except if it's completely detached or very largely detached, it's best to go to the operating theatre, because if you're on the vertical position and you put air in, it can actually scrumple your Dmek graft and it goes to the wrong place altogether. So it's better that the patient is lying flat. Now, if you have a pre-placed 5 o'clock paracentesis, if you're a right-handed person, then you can go in with the cannula quite easily at the slit lamp. And even if you haven't got one or it's closed, then you can create a new one with a 15-degree blade quite easily. Now, with rebubbling, there's also controversy as to whether you use air or SF6 and at what concentration. Or if you use a cannula or a needle. Cannula, of course, it can leak through your wound. If you use a needle, there's more chance of damage, but there's a higher chance of retaining more gas or air within the anterior chamber. So let's end with some controversies. So we've already talked about graft marking or stamping. Some people will not do stamping or no marking, and other people will say, I really don't want to do it. I can be very careful and be fine. And then equally for people who do surgical PI or YAG PI or no PI, for people who are the no PI camp, they will say, well, I dilate my pupil afterwards, then there's no chance of pupil block. YAG or surgical, well, YAG is probably better, but that means another visit, because with surgical, you can have bleeding or fibrin, and that can affect your Dmek adhesion. As far as gas or SF6 is concerned, SF6 probably holds the graft better, but you have more pressure problems. And of course, pressure problems can damage your optic nerve, especially if there is some glaucoma already. And also SF6 is a very potent greenhouse gas. And of course, it adds to the expenditure as well. Hydrophilic or hydrophobic IOL, well, both of these can opacify in the presence of air or SF6, possibly a low incidence with hydrophobic IOL. So probably it's best to use hydrophobic IOL if you're doing a Dmek. We've discussed this already. And the long-term steroid question, I think it is generally believed that if you use long-term steroid, just 1 drop a day, it reduces the 2 to 3% rejection rate down to almost 0. So I think I probably run out of time, so I won't go and tell you about this one. And I'll see, I want to thank Nancy for inviting me, and thank Mohammed who worked with me and who's a good friend, and some of my past fellows who are all good friends. If you have any academic queries or want a copy of this, do email me. This is my private practice address. And if you want to ask anything about the Royal College of Ophthalmologists, that's my college email address. And sorry for the technical problems and sorry to have run over. Thank you.
Thank you very much, Professor Liu, for this comprehensive presentation.